We move then to the next item on the agenda, which is the strategic framework for specialised services. And I'm very pleased to welcome to the table Jonathan Fielden, who is our Director of Specialised Commissioning. Jonathan, I'd like to invite you to introduce the paper and then perhaps invite Noel Gordon, who's the Chair of the Specialised Commissioning Committee, to follow. But over to you.
Thank you very much. And Specialised Commissioning, which covers the 146 prescribed services the Secretary of State tells us to commission, covers from the rarest of conditions through to many conditions which cover more patients across the country, but are very often high cost, but need to be located with highly specialised teams to get the care that patients require and the outcomes and quality outcomes that we need. So in the 2 months that I've been in post full time, being out and about round the regions and with colleagues and patients, one of the coherent asks has been, well, how does Specialised fit in with the 5-year forward view? And that is what we are aiming to address now and over the next 3 months as we take this framework out. Very clearly, we are linked to the three parts of the vision of the 5-year forward view: better health, better care and better value. On better health, the health and wellbeing gap, for Specialised, getting into prevention is actually, most of the patients are quite a long way down the pathway. For us, this will be about focusing on the personalisation and precision agenda, wherein first we'll be reducing the harm to patients, because we can focus these conditions, the treatments in a better way for them. But that will also allow us to treat more patients by focusing the care in the best way. The second aspect around the care and quality gap is there's been a lot of advantage in bringing the specialised commissioning nationally to get the national consistency of process and outcomes, the national clinical advice, but that has fragmented some of the pathways. And when you fragment pathways from a patient's perspective, that doesn't deliver the experience or necessarily the outcomes that they are after. So we need to link those pathways back together. And then, very importantly, about the finance and efficiency gap. Specialised commissioning is 15.66 billion. It's 14% of the NHS budget. It is vitally important that that money is utilised in the most effective way to give best value for patients. And as we go ahead, the challenges in that budget are as great or greater than many other aspects. But by controlling that in the way of getting best outcomes for patients, we can ensure that other patients outside the specialised arena also get the care that they require. So the framework has three broad areas. How do we link into the place and population-based care? How do we provide the national support to ensure the quality of outcomes? And how do we maintain the financial grip and value across that? So in the first area, there are three aspects. So we're working closely with our SDP colleagues, and we've just heard about the SDP process. So with our Sustainability and Transformation Plan colleagues, what are the patient-person focus, what are the populations of Specialised which are best for us to be working closely with you on? With that, then what is the provider footprint, the provider configuration that is needed to deliver that in the best way for your area? And that will lead to some changes. And then thirdly, the collaborative commissioning. How do we work best with our CCG, SDP and hub colleagues around the models of commissioning to get the best outcomes for our patients? For the national level support, we need to have consistent national level clinical leadership and advice. We have we're just completing the reconfiguration of our clinical reference groups to ensure we have the right clinical and patient public voice support at national level to get those consistent outcomes. There is a lot to do on our business information, making sure we've got the right information to deliver the change that we need for our patients. We need to ensure that we are working closely with research. Specialised commissioning has very many of the most innovative aspects of health across the NHS, and how we best focus our resources and link to that agenda and bring in treatments at the earliest point that work, but also mindful that that will be stopping some treatments that no longer work effectively or processes that no longer work effectively, and linking that back to our clinical and patient advice on that. And then finally, around the financing. the finances, it's vitally important we maintain that national, the grip that we've had in landing the budget for 2015-16, which is great improvement over the last 2 to 3 years. But doing that, focusing those resources in the best way to get the best outcomes for our patients. So what would look different from a patient perspective? We want to work with our patient public, our citizens, to ensure that we are defining over the next 2 to 3 months the outcomes they wish to see from Specialised. We want to make sure that those pathways are linked and linked back together. For our clinicians, we want to make sure that they have that consistent national approach, but they have very clearly defined pathways located back as closely to where the patients need that care. And for our provider and commissioning colleagues, it's making sure we have the right configuration of providers and the right mechanisms of commissioning, working particularly with our SDP, our Sustainability and Transformation and colleagues, to ensure that this is the best way within the resources we have of delivering the outcomes of care that our patients wish to see.
Good. Jonathan, thank you very much for the introduction. Let me open it now for questions and discussion from around the table. Bruce and then Michelle.
Jonathan, in terms of linking this to the 5-year forward view, I think there are some other aspects which are worthy of consideration. The first is the role of specialised commissioning in rolling out innovation, and that may sometimes be within the context of a rapid response or a response to some kind of emergency. And I'd just like to bring to the board's attention, 2009 there was a terrible flu epidemic, and we needed to have more beds in the country to provide a complicated service called extracorporeal membrane oxygenation. And there were only 2 beds in the country. And by using the processes which are embedded in specialised commissioning, in other words, by defining specifications and by introducing very focused clinical leadership, in this case under the leadership of a single individual called Richard Furman from Leicester, we were able to roll out from 2 beds to about 60 beds in a matter of a few weeks. And the end result of that was that we had some of the best results for extracorporeal membrane oxygenation in the world, where our national results were equivalent to the results of the best single centres in the United States. And I think we learnt a lot from that about how we can use the offices and the processes of specialised commissioning for pushing out innovation when it needs to be very, very quickly across the NHS.
I think you're very right on that, Bruce. The national consistency, the national standards, the ability to roll out at pace, but then linking in very much to how it's delivered locally so patients get the care and the quality at the speed they need.
Okay, thank you. You've described the strategic framework very well. Could you just talk us through how you'll be developing the outcomes of the strategy over the next couple of months, and in particular how you plan to engage, involve, co-produce the strategy with citizens, and how they'll be involved in the implementation of the policy?
So already we have floated what you see before you with our Patient and Public Voice group. There were some of the first people involved with this, and with our clinical colleagues for that. The sense is that, yes, this is in the right direction, but we need to put some more detail around it. Hence, over the next 2 to 3 months, working with our Patient and Public Voice, our strategic partners, our stakeholder groupings, and with our clinical groupings, to put the detail around so that we can get the outcomes that matter to patients, as well as the outcomes which matter to our clinicians right. The clinical reference groups in particular will be key. We have reformed and focused those around the priorities that we need for the NHS, and we're pointing the chairs and the Patient and Public Voice colleagues into that, and we've firmed that up. Around our prioritisation, we're just about to land the prioritisation process for CPAG, and that again enhances the amount of public involvement within what happens on Specialised. We're very keen that we see this as a dynamic process of firming how we link to the 5-year forward view, but see patients absolutely at the heart of defining the outcomes and experience that they need. And particularly in the areas of rare disease, where really it is a process of how those rare diseases matter to patients that we need to be linking to them to get the best value for them.
Okay, thank you.
Thanks. Thanks, Jonathan. Obviously sounds, sitting here, very sensible, both and the national excellence and local connection. But where does CCGs, it might look a bit different for them. How are they seeing this?
So in the last 6 months, we've revamped our collaborative commissioning and working closely with CCGs and Dr. Nick Harding from the Midlands in particular, and the NHS clinical commissioners, to see how we can best do this, and we will continue to work with them. I think there are sort of 3 aspects to that. The desire that our the CCG colleagues and SDP colleagues have in this area, their capability and their capacity to do so. And that varies. We have some areas of the country, such as Manchester and increasingly South East London, where they are they're advanced in both those areas. But others, they are moving along in all those 3 aspects. Very much we want in every SDP for our colleagues to be at the table for these discussions. We want them to be involved in the discussions. As we move with greater capability and greater capacity, such as with Manchester, towards more delegated and devolved, there are legal aspects, and we're working very closely, particularly with Manchester, to make sure that we get this right, to have the national consistency, but delivered in a way which links in locally.
You asked whether I should just address more contextually what we've been doing in the Specialised Commissioning Committee, Malcolm. And as you know, since it was set up 8 months ago, we've probably devoted the majority of our time to thinking through what is the strategic framework that will keep us in line with the 5-year forward view and help us implement many of the complexities that we face. And what this paper sets out, I think I'd characterise as our base camp 2. We're on the way toward a more sophisticated model of commissioning. We are addressing the sort of triple witching of very fast rising demand, a huge pipeline coming forward of innovative drugs and technologies. Each of those drugs gets more expensive. And a supply configuration that is not ideal, is fragmented in places, and which we want to rejoin for a number of different pathways. And unraveling that triple witching is the start that we have made today with this strategic framework. There is a way to go. We have still a backlog of policies that we need to deliver on. We still have to work on the co-commissioning structure and exactly how we will co-commission across different levels and possibilities that we have within it. And also how we deal with our own prioritization processes for new drugs and devices that become available each year through our commissioning intentions policies, for which we have indeed engaged the public voice, at least on one occasion recently, and now a second occasion that's going through a consultation process which will be more or less completed by next week. And so what we've got is, I think, a hugely progressive start on rebuilding the way we approach specialised commissioning in the NHS. The destination is one that we need to fix upon totally collaboratively, and with many active patients groups who are guiding us. But I think today is a really good start. There's a lot of implementation to do. There's a lot of heavy lifting to do in the implementation. But it's giving us, perhaps for the first time in relatively recent memory, a very clear journey and direction.
Jonathan, thanks. Great summary. Obviously, I sit as a non-exec on your committee, so I have inside track on some of the conversations. But as a clinical geneticist, I have always had to give voice to the people with rare diseases, most of which are genetic, as you know. And it's worth perhaps just teasing out, we talk about 7,000 rare diseases, but some of them aren't that rare, the hereditary cancers, cystic fibrosis, sickle cell disease and so on. But there are some that are vanishingly rare, and giving voice to that community can be challenging when they often feel that their treatments are not being pushed to the front because of that budgetary grip that you have to maintain. So I think the two aspects to the question, first of all, how do we protect national provision for some of these very rare conditions, like, say, the mitochondrial diseases or muscular dystrophies, where it's just not practical for STPs, CCGs, and any other segmental group to look after them. So we need to think about it at national level. How do we protect them? Because obviously they can help with that budgetary management to some extent. But also we are all aware of the dramatic expansion of this field. I mean, we're finding new rare diseases on a weekly basis now, thanks to the advances in genomics. So this 14% figure, I've asked in the past, where did we get 14% from? And it's almost inevitable that that's going to come under specific pressure as these very rare conditions start to become treatable with often very expensive drugs. So how do we look after the very rare diseases, and how do we handle this question of the fact we might need a bit more money?
Thanks, John. Absolutely, for those, it's vitally important we keep that national approach, that national consistency, because it is only by that we'll get the outcomes and the experience that our patients require. So they will need that national approach. Some of the conditions will link more closely to larger footprints, such as a Manchester size, for example. So there will be a national approach, there'll be a regional hub approach, and then there'll be those conditions which are more suited to the more STP. So we need to make sure we get that right, we don't lose the quality and consistency of that. I think where you identify through the many of the innovations and research side, much of which also sits within those doing specialised care, identifying new challenges for us, it's vitally important that we use the personalisation to focus on the treatments that work. We monitor, we research, and we analyse to make sure they continue to work. And in that way, that allows us to free up budget from those areas where perhaps things don't work. We're going to need to work with our clinical colleagues and the public very clearly about not doing the things that don't work, to allow us the space and capacity to do the things that do work. Innovative ways of working with industry and pharma around how do we pay for this over a longer period of time with new ways of looking at that. Because only that way will we be able to get the treatments we need for the patients that need it, but in a way that doesn't mean that the specialised budget sucks everything out away from the rest of health. It's vitally important that the specialised budget, 7% increase this year, 4.8 next year, 4.5 for the next 2, and then 5, that we hold within that so the rest of the NHS can get the funds they need for the transformative change that's required there too.
Okay, thank you.
And I guess that you would expect as the chairman of the audit committee that is a material area of focus, and because on the one hand this is hugely exciting, we can bring better treatment to patients. On the other hand, it scares the living daylights out of me a bit about the pipeline of what's coming down the track, and the potential costs and crowding out of that on other things. So I guess really to you and to Paul is, how can you assure the board and me that we're going to be able to keep within the financial envelope that we have described, which is already twice the growth that the rest of the service broadly gets. So Specialised is continuing to get a bigger share of the pipe, and that's appropriate, but clearly the risk in this is very high. So the assurance, I guess, we're looking for from you two about how we keep financial discipline.
So I think we've proven over the last 3 years how we've improved year on year to landing the budget in 2015. That we've done that through strengthening the teams, but also strengthening the conversations that we're having between the teams and our particular hub teams and providers around how best to utilise the funds that we have. We will need to continue that grip going forward. How we have changed, as the board agreed a couple of months back, the Cancer Drugs Fund to make sure that we can have the best drugs coming in, but also recognising when they need to come out in a sustainable way. How we work with NICE to ensure that we have the right drugs coming through in an affordable way. So that means that we can deliver for the patients that need it in a balanced way, rather than allowing all the funds to come through into Specialised. It will be challenging. I think Paul has said at other times at board that this is one of the most challenged areas of our budget. But we have the teams, I believe, in place. We have the real conversations, as can be seen from the contracting rounds this year, and we're determined going ahead with what we outline in the strategy to maintain that going forward, but it will remain challenging.
Anything to add?
Little to add, really, because I think you've made most of the points I'd want to make. The only thing that's perhaps worth making a link to is the Right Care programme, which we often think of as being a substantially CCG-oriented or local health economy-oriented programme, which it undoubtedly is, but it absolutely has application for specialised commissioning to ensure that in this national set of services of all, we've got consistency of what we do, and I think that will be an important part of it. Not over the next month or two, but over the next few months, we'll get that underway, and it will have its impact.
I think Malcolm, the Audit and Risk Committee, will at some stage want to have a deep dive onto how we're managing the risks associated with Specialised, because in my internal risk register, this is right up there at the top.
Are there any other comments or questions? No, in that case, Jonathan, thank you very much for the presentation. The board has expressed, I think, a number of interests and anxieties and risks culminating in what David has just said. We will want to keep it closely under observation, but you've given us assurances today. Can I invite the board then to agree the next steps, which are set out effectively in the final slide of the paper, on the basis of the presentation we've had today? Good. Thank you all very much. Thank you very much, Jonathan.